to the next topic, that is topography and tomography interpretation. What you should not know. You should know in keratoconus by Dr. Aswathy. She is also from Government Medical College, Thrissur.
Good morning all. Even with a very careful physical examination, sometimes you might miss the early signs of keratoconus. It is then that topography and tomography play an important role. So what is basically the difference between topography and tomography? Topography is basically the surface characteristics, the surface curvature and the details. But tomography is more of a 3D reconstruction where many things other than in addition to the anterior curvature can be studied. So we have basically three techniques: the Placido disc based, which is what we call as topography, then slit scanning system and the shame-plug imaging, which come together constitute the tomography. Coming to the Placido based system, that is a video keratoscopy, a Placido disc-like thing is used to reflect Myers onto the surface of the cornea, and depending on the distance between the Myers, you can assess the curvature of the cornea. When the distance between the rings are greater, the cornea appears to be flatter, and when it is lesser, that part of the cornea is steeper. So we also get a color-coded map from this, where the warmer colors represent a steeper cornea and the cooler colors represent a flatter cornea. Next is a scanning slit technology, which is utilized in OBSCAN. Here, around a lot of slits, maybe around 40 slits, 20 from the nasal and 20 from the temporal sides are projected onto the surface of the cornea, and on each slit, around 240 points are being analyzed. So the whole of the cornea is being analyzed this. And in the shame-plug imaging, the shame-plug technology is being used. And the advantages of this technique is that it facilitates a 3D reconstruction of the anterior segment. Therefore, in addition to the anterior curvature, we can also know about the posterior curvature, the corneal thickness, the anterior chamber depth, in addition to details about the lens also. Also, it has much greater area of coverage. The limbus to limbus area of the cornea is covered, whereas in topography, only about 40 to 60% of the cornea is being covered. And also, this is not affected by tear film abnormalities, unlike in topography. So this is what we get, report of the pentacam. In the first part, we have the patient details. The patient details we have to enter correctly, especially the year of birth. The age of the patient is very important in comparing with the data. Next thing we have to look at is the quality specification or QS value. If it is given okay, then the scan is fine. But if any of the other data is displayed, data fix or model, then you might have to repeat the scan. Below that is the Q value, which represents a measure of the corneal sphericity. And in normal cornea, the value is between 0 to -1. If the cornea becomes hyperprolate, as in case of a keratoconus, the value becomes more negative. Next is the keratometry values that are depicted. If the keratometry Kmax value goes above 47 diopters, you have to be suspicious of an ectasia. Next, we have the quad map that consists of 4 maps. One is the anterior sagittal curvature, which is similar to the topography image that we get. Then there is the anterior elevation, posterior elevation, and corneal thickness maps. Coming to the axillar curvature map, here, in addition to the curvature of the anterior corneal surface, which is represented as diopters at each point, we also can identify certain shapes. These shapes can be either symmetrical, round, like the round, oval, or symmetric bow tie, which is usually normal, but when the Kmax exceeds 47 diopters, you have to suspect an ectasia. Asymmetric shapes are there, like the superior steepening, inferior steepening, or asymmetric bow tie with superior or inferior steepening. When the difference between the inferior and superior part is more than 1.5 diopters, you can suspect an ectasia. There are skew deviations. When the skew is more than or equal to 22 degrees, then also you have to suspect an ectasia. Special shapes are almost always abnormal, like the butterfly, crab claw shape, and irregular. So these are the high risk and moderate risk characteristics which can be ascertained from a topography map, anterior curvature map. Next is the pachymetry map. In this, there are two things you have to look for. One is the thinnest location, the thickness at that region, and the location of the thinnest point. If the thickness is less than 470 microns and if it is inferiorly displaced, the thinnest location is inferiorly displaced for more than 0.5, then you have to suspect an ectasia. Next we move on to elevation maps. This is called anterior float or posterior float. Now, to get an elevation map, you have to compare the cornea to a reference surface. Now, if the reference surface is a planar surface, then even mild, advanced and normal corneas look similar. So, in that case, we have to take a reference surface which as closely approximates the normal cornea as possible. So, after much of deliberations, a best fit sphere from the central 8 mm optical zone has become the standard reference surface. So these are the characteristics we have to look for in an elevation map. If the anterior surface is elevated for more than 15 microns and if the posterior surface is elevated more than 20 microns, you have to suspect an ectasia. But a problem is there, these elevation maps, these reference surfaces are derived from the anterior curvature map. But if it is an ectatic cornea, then that causes steepening of the reference surface. So a part of the cone will be masked. So to circumvent this problem, we have come up with enhanced reference surface which excludes a small zone of 3 to 4 mm surrounding the thinnest location. So when that area is excluded, it flattens reference surface and allows the ectatic region to become more prominent. So this is in comparison, the cornea in comparison to the best fit sphere and the enhanced reference surface. This again, it is more prominent with the enhanced reference surfaces being used. Now this brings us to the Bellin-Ambrosio enhanced ectasia display, which is a comprehensive refractor screening display incorporating both the enhanced reference surface and pachymetric progression graph. Now in this image, you can see that the upper two ones are with reference to the best fit sphere. The middle two images are in reference to the enhanced reference surface, and the lower two images is the difference map. That is the difference between the elevation map using an enhanced reference surface and a best fit sphere, and the difference are very much enlightened here. When the difference between the two is more than 7 micron, it is presented in red. When it is between 5 to 7 microns, it is yellow, and less than 5 microns, it is represented in green. You also have a corneal thickness map represented here and a corneal spatial profile here. Thickness spatial profile. There are 3 lines here which represent, this is the normal and this is 2 standard deviations above and below. When this cornea, the values of this cornea grows through the center, then everything is okay. When it approaches either of these lines, or when this slope goes too much abnormal, then that is a cause for concern. We also have various D values represented in the bottom part, where when this is represented in white color, then it's fine. If it is yellow, it's a cause for concern, and if it's red, then it's almost definitely abnormal. ABCD classification is described already, and ABCD classification is also represented graphically in the map, and you can ascertain the staging of the keratoconus from this. And we also have a Bellin ABCD progression display here, which is used to determine the ectatic progression, and up to 8 examinations over time can be displayed using this graph. Now here you can, all the 4 parameters A, B, C and D are represented here, and you have 2 type of gates, the green gates used for early disease and red gates for established keratoconus cases. When these value reaches these grades, then you have to be concerned and it is time to take up the patient for treatment. Thank you.
Thank you, Dr. Aswathy, for the